Greetings, this is Ogan Gurel, and I hope you're staying well. This is a review and update of COVID-19 on the 23rd of April, 2020. In this presentation, we'll be talking about several questions. For example, what do we know about the virus? How can we stop it? How does it cause disease? What are the prospects for a vaccine? Can one be reinfected? How does one test for COVID-19? Do antibody tests work? Does the virus mutate? Are effective antivirals possible? And many other questions. I'd like to start with a famous quote most of you are familiar with. The phrase, knowledge is power. It's attributed to Sir Francis Bacon, the founder of the scientific method. But as we don't know everything about this virus and certainly learning new things every day, I think we should modify this phrase to say some knowledge is power. Even though we don't know everything, some knowledge will help us in handling this situation. So the outline for this video is we'll talk about the virus, some basic epidemiology around the framework of mortality and transmission, how the virus attacks and causes disease, how we fight back from the virus, how the virus spreads, and finally, what is to be done. So focusing on the virus, and this is somewhat a summary from a previous video posted on this channel. So what is a virus? You can see this colorized picture showing the yellow virus particles on top of a human cell. And a virus is essentially genetic material contained within an organic particle that invades living cells and uses those cells' host machinery to produce new virus particles. So an important question is, are viruses alive? We'll answer that question very shortly, so keep that in mind. So this virus is genetic material contained within an organic particle. Actually has three parts. From the inside to the outside, the inside has the nucleic acid, which is RNA. Then there is a surrounding lipid membrane. And thirdly, there is a spike protein on the surface of the virus. This is a simplification, but those are the three major parts. Now, in terms of the nucleic acid, that's the genetic material, as I mentioned, and it is important to note that it is RNA, not DNA. RNA has a propensity to mutate, and that has implications for immunity and vaccines. This RNA is also used for testing the real-time PCR or polymerase chain reaction test. The lipid envelope is a kind of greasy layer, and it determines the environmental viability of the virus. And you can see from the electron micrograph, it's a little bit squishy. And in fact, that's why soap and alcohol disrupt this membrane and destroy the virus. Thirdly, there's the outer spike protein. This determines the target. It is also blocked by antibodies, and it is used for testing the two types of tests, the antigen test and the antibody test. So back to the question, are viruses alive? So the answer is no. There are only two ways to get rid of a virus. They are to physically destroy it and to have it cleared by the immune system. In other words, you can't really kill a virus. You get rid of it through destroying it or having it cleared by the immune system. And this will have very important implications later on. So now to the second part, the basic epidemiology. We'll use this framework, which shows the fatality rate, CFR, case fatality rate, and transmissibility, R0, of a variety of pathogens and viruses. So you can see the fatality rate on the vertical axis in a logarithmic scale, and you can see the transmissibility, R0, on the horizontal axis. Generally, there's an inverse relationship between transmissibility and fatality. In other words, more transmissible, such as measles and chickenpox, are less fatal, and less transmissible, such as Ebola and MERS and bird flu, are more fatal. Where is the new coronavirus? It is in the middle space. It's been called the perfect pathogen, somewhat transmissible and somewhat fatal. And how does that compare to seasonal flu? Seasonal flu is less transmissible and less fatal. Spanish flu is believed to have been slightly more fatal and maybe a little bit less transmissible. So let's compare the seasonal flu versus COVID-19. Again, in terms of those two parameters, mortality and transmissibility. So the hospitalization rate for COVID-19 is about 10 times that of the seasonal flu, and the case fatality rate also is about 10 times that, estimated to be between 1 and 3.4%. Now, the transmissibility, fundamentally given by that R0 value, which is the number of people affected by an individual with the disease, is also greater in the case of COVID-19, with R naught between 2 and 2.5 estimated early in the experience when the outbreak first occurred in China. Another very important factor in transmissibility is the incubation time, which is significantly longer in COVID-19, up to 2 weeks as compared to essentially 4 days or less with the seasonal flu. And that transmissibility is increased when there is a longer incubation period where virus is being uh, shed. Some recent data suggest that these numbers, the case fatality rate and the R naught, may be different than these initial estimates. So how does the virus attack? How does it cause disease? So again, on this framework, we're going to focus now on what causes disease, the fatality rate, the vertical axis. So the primary mechanism is the virus attacks type 2 pneumocytes in the lung and a protein called ACE2. So this is a picture of the lung. You can see it's deep down in what we call the alveolus. And the alveolus is where gases, air, and blood will exchange. So you have a thin barrier between the air pockets of the alveolus and the blood, and that's how carbon dioxide and oxygen are exchanged in the lung. So there are two types of cells in this alveolus. You can see the type 1 pneumocytes are thin. They cover about 95% of the surface, and they are involved in gas exchange. There's another type of cell called the type 2 pneumocyte, a more roundish cell, covers only about 5% of the alveolar surface. And it secretes a very important substance called surfactant that allows the alveolus to stay open and function effectively in gas exchange. It turns out that the SARS coronavirus 2 infects these critical cells. That's a key vulnerability, resulting in this acute respiratory distress that you can see on this X-ray with these patchy spots around the lungs. So a little bit more specifically, and again, this is a review and a summary from a previous video. How does COVID-19 cause lung and cardiovascular disease? So in the lung, there's an important protein called angiotensin converting enzyme, or ACE. And there are two types of ACEs. One is ACE1, which tends to increase blood pressure. That's the function of the enzyme. A little bit simplified, but that's essentially what it does. And then there's another protein called ACE2, which tends to decrease blood pressure, and it also functions to decrease inflammation in the lungs. So this is the ACE2, the blue protein, and it's found a lot on the type 2 pneumocytes, those round cells that we mentioned that are about 5%. Of note, it is also on other cells throughout the body, so it's not just on the type 2 pneumocytes. This is the SARS coronavirus spike protein that we talked about, and it binds directly to this ACE2, and that's the target for the virus. So the pathology or disease caused by this virus has two manifestations. One is the cellular pathology. What does it do to the type 2 pneumocytes? The other one is the molecular pathology. What does it do by attacking the ACE2? So by destroying the type 2 pneumocytes, either directly by the virus or the immune system trying to clear the virus, or decreasing the angiotensin converting enzyme 2 by basically killing those cells, you get severe COVID-19 disease. So by taking away those type 2 pneumocytes, you reduce the surfactant and you reduce the gas exchange. People cannot get oxygen as easily. And then if you reduce the ACE2, you get late stage inflammation and fibrosis, and you see those changes that you see on X-ray or CT. Now, on the molecular level, the reduction in ACE2 also causes blood pressure abnormalities. And so you have hemodynamic abnormalities. In other words, the cardiovascular system and the heart are affected. But we know now that COVID-19 also affects beyond the lungs. And again, in the lungs, it's impaired gas exchange. So hence, patients need a ventilator. In the cardiovascular system, you disrupt the blood pressure control. You also have clotting problems, and so you need ICU. But it's also known to infect the intestines. About 20% of patients present with diarrhea, and there are ACE2 receptors, there are ACE2 proteins on the small intestine. The eyes are also involved. In the early cases in Wuhan, you might remember that the ophthalmologist was the first whistleblower doctor that observed these eye problems. The brain has also been involved with stroke, seizures, and a meningitis, which is rare but concerning. And the nose is also very interesting because there's a loss of smell, sense, which we will talk about later. And damage to the liver and kidneys, other organs, may be related to immune damage, blood pressure changes, or drug toxicity, as it's typically in severe disease. Some of you may have heard about Covid Toads. Typically in younger patients, you see blistering, you see color changes and a rash. It's believed to be an inflammatory process or some form of blood clotting issue that causes these Covid Toads. So summarizing the symptoms of COVID-19, fever, cough, shortness of breath, sore throat, loss of smell, we call that anosmia, or taste. It's typically 2 to 14 days after exposure. The flu also has fever and cough, but there's a little bit more upper respiratory tract with sore throat and runny nose, as well as more generalized symptoms of headaches, fatigue, and myalgias, which are body aches. And allergies are more nose and eyes, with itchy, runny, blocked nose, and itchy, red, or watering eyes. So the shortness of breath is a very key symptom in COVID-19, but it's not always. There can be silent hypoxia because of this loss of this surfactant. The lungs are not exchanging gas very well. And so this is an alveolus, as I mentioned, the air pockets. Here's the blood, carbon dioxide out, oxygen coming in. Pulse oximetry measures oxygen levels, and normal people have about 94 to 100% pulse oximetry. COVID pneumonia, even without shortness of breath, can be as low as 50%. So there's been some discussion about pulse oximetry being used for early detection of the clinical signs of COVID-19. Loss of smell is a key symptom, and there was an app that was distributed to 1.5 million people in the UK reporting on their symptoms. 579 were COVID-19 positive, and loss of sense of smell and taste was found in nearly 60% of the COVID-19 positive patients, but only 18% of those COVID negative. So this is a chart of all these patients and the number with different symptoms. So you can see the dark orange one with the loss of smell has a lot of patients involved in there. And actually diarrhea is not so many, and shortness of breath is not as much as anticipated. So this is another chart showing that what we call the odds ratio and loss of sense of smell and taste seem to be very correlated with COVID-19. Another very important issue is how important is viral load. So this is a nasal swab test that you've heard about, and you insert this all the way back here. The PCR, or polymerase chain reaction, is used to detect the viral RNA, and it took a certain amount of time for that reaction to occur. And if you have more of the virus, that you need less of the reaction to get a positive result. If you have very little of the virus, you need more of the reaction. And so that delta CT here is the number of PCR cycles to become positive. And in general, a low DCT means more virus. In other words, you don't need a lot of reaction because there's a lot of virus already around. So this chart shows from a Chinese study, mild COVID-19 and severe COVID-19. And you can see that the severe COVID-19 had a lower CT, in other words, less PCR cycles, and therefore they had more virus. This is very important because people have talked about older people being susceptible, but we've seen young people as well. In fact, the famous Dr. Li Wenliang, the whistleblower who brought this attention to the Chinese authorities, was age 33. And of course, we've heard about many healthcare professionals, young and old, who have succumbed to the disease. And the amount of exposure is probably a key factor. And there are those who have left us. So if we look at the latest Worldometer, we see 2.6 million cases, 184,000 deaths. That's about 7% death rate. And I'm not saying that's the case fatality rate, but we see that that's the issue. So many people have left. I'm just going to summarize a few of them here and let you look at their faces. So I show these faces, some of them maybe don't know that it's many more. But we have statistics and we have support. So now I want to talk about how we fight back. So how do we fight back? What is the purpose of the immune system? The immune system, the goal is to destroy or eliminate foreign invaders, bacteria, viruses, fungi, parasites, etc. We call these antigens. Antigens are the proteins on these foreign invaders that are different, and we recognize them and we develop antibodies. So just an overview of the immune system. Immunity can be both innate and adaptive. There's an innate immune system that responds to generalized antigens, and there's an adaptive immune system that will get better, will adapt to a foreign invader, and that's the concept of immunity. So focusing on adaptive immunity, we have two types of adaptive immunity, natural or artificial. And natural adaptive immunity can either be through an infection. There's also the possibility the mother can give through the placenta to the fetus or through breast milk to the infant, actually giving antibodies, and that would be natural passive adaptive immunity. On the artificial side, we can have serotherapy, convalescent serum, in other words, antibodies from patients who have had the disease, and we give that artificially. And of course, the most important form of artificial adaptive immunity is active form with vaccination. So that's an overview of the immune system. Now, an important concept in the immune system is that the secondary response to a antigen is typically stronger. What is this response? This is the coronavirus or any other virus. This is the ACE2 target. And if you have these antibodies, neutralizing antibodies that block the virus from attacking the system, that's the fundamental immune response. A little bit simplified, but that's the fundamental response. So this is the antibody concentration. Here's an antibody. If you give the antigen, this is the primary response. But if you give the antigen again, the second time, look at the response is much higher. In other words, more antibody and faster. We call that the secondary response. I was simplifying a little bit. There are two types to the immune system. There's the antibody-based as well as the cell-mediated immunity. And this also has an enhanced secondary response. But the concept is the same. The secondary response is stronger. So immune system is very important. So one of the most important things people can do to strengthen and prevent COVID-19 is to boost your immune system. So get enough sleep, update your vaccines with the seasonal flu vaccine, although it's now a little bit too late for that, at least this season. And for older individuals to have their pneumococcal vaccine updated, PCV13. Healthy eating is very important to improve the gut microbiome, as well as decrease inflammation. This includes whole plant foods, yogurt and other probiotics, healthy fats, namely non-trans, and unsaturated fats, and to limit added sugar. Moderate exercise is very important. Managing stress through meditation, exercise, walking, exposure to nature. And there's a question of supplements. It's very important. Water is the most important supplement to stay hydrated. If possible, spend some time outside and get sunlight, vitamin D, and to take recommended dose about 1,000 milligrams per day of vitamin C. There's no evidence for mega doses. Getting enough sleep is probably the most important thing to boost your immune system. So is a COVID-19 vaccine possible? This diagram is a little bit complicated, but it shows you that there are different types of vaccines that are possible. First one is a viral vector vaccine. In other words, you use another virus to put some of the antigen in there through genetic material. A Chinese group in the University of Oxford has phase 1 clinical trials there. There's a DNA-based virus. There's a possible RNA-based virus, and Moderna and American companies developing a vaccine around that. There are live attenuated viruses. In other words, it's a real virus, but it's been inactivated or attenuated. Another group in China is developing a vaccine around that. There are protein-based vaccines. And finally, the immune response or convalescent serum that we talked about. So the good news is that there are over 40 early development vaccines. 4 are in phase 1 clinical trials, as we mentioned, the viral vector, the RNA, and the live attenuated. There are 2 BCG trials. BCG is actually a vaccine for tuberculosis, and it's been shown to have some effect on severity of disease. And the other good news is that this is an RNA virus, and they're likely not latent or dormant in the body, unlike hepatitis or herpes. People who are familiar with hepatitis know that it can be chronic, and herpes is also chronic. It's latent, it's embedded in the DNA of the host. Also, unlike HIV, coronavirus spares the immune system. The bad news is, like the common cold, coronavirus is about 15% of the common cold. Antibodies seem to be short-term. And also the antibodies may be relatively ineffective, and we'll talk about those points. The fact that it's an RNA virus and doesn't insert itself into the host DNA is good news, but the fact that it's an RNA virus is also bad news because it tends to mutate. That's why influenza, which is an RNA virus, requires a vaccine every year because it mutates and changes. And another barrier is anti-vax sentiment. Social issues and education, public education issues could be a barrier. So putting all this together, I believe we probably need what we would call a polyvalent vaccine, not just working on one part of the antigen or one part of the vaccine. And we may need a multi-vehicle or multi-step vaccine, not just a viral vector, not just live attenuated. We might need a much more complex cocktail vaccine. This implies a multidisciplinary, multi-company effort. We need some sort of organizing framework around this. In Korea, a couple of weeks ago, the President Moon announced a vaccine initiative with about $170 million, and Bill Gates has also joined that. So that's very important. And we also need strong public education because the anti-vax sentiment can be an issue, and we have to be aware that this is not just about science, but also about public education. So why may antibodies not offer as much protection? Remember, the virus has three parts, but actually there is a fourth part, and there's the surface glycan sugars. So the virus is composed of nucleic acid, lipid, protein, and also sugar. So this is the spike protein here, and you can see these fluffy extensions are the glycan shielding. This is a model of this spike protein, not just the protein, but also the sugars around it. So about 30% of patients have failed to develop high titers of neutralizing antibodies. So that raises the next question: is reinfection possible? So some of you may have heard that South Korea has reconfirmed cases, and these are being investigated. So there are four possible causes. One is redetection, not really reinfection, but redetection. And redetection can be a testing problem or some form of latency. The testing problem can be the original test when they were at the end of their illness was a false negative, didn't pick up very small amounts of the virus, it was actually still there, or the repeat test was a false positive. It's picking up RNA, but actually that RNA by the PCR test is not pathogenic. It's just a remnant of the destroyed virus. The latency is unlikely. As I said, it's not a DNA virus like hepatitis, herpes, or retrovirus. The second category is reinfection. Reinfection could be immune failure, which is possible, as I mentioned. The antibodies may be weak, and also it could be mutated by it could be infected by a mutated virus. This is unlikely, but mutated forms of the virus have been seen. More on this later. So four possible causes: testing problem, latency, immune failure, or mutation. The most likely is a testing problem with some sort of repeat false positive. There have been reports by the Korean CDC that these reinfected patients seem to be very infectious. And what about treatments? So just a couple of days ago, the NIH put out COVID-19 treatment guidelines on the 21st of April, and this is a little bit difficult to see, but it was a consensus statement by American College of Chest Physicians, Emergency Physicians, Thoracic Society, Disease Control, CDC, many groups came in a consensus. And so they came up with these guidelines based on what everybody agreed on. And that's actually how they came to these guidelines is important. So I'll just summarize it in terms of prophylaxis, critical care, and therapeutic options. Prophylaxis is prevention. Pre-exposure and post-exposure, they said there's basically no prophylaxis. Unlike Tamiflu, which is an antiviral with influenza, it's used to slow down the virus in the case of influenza. We don't have any prophylaxis for COVID-19. And in terms of critical care, they basically recommended some fairly conventional hemodynamic and ventilation advisory. I'm not going to go into the technical details of that. That is more for medical professionals. Now, in terms of therapeutic options, they talked about two options, antivirals, and the second one being host modifiers or immune-based therapy. How can they improve the immune system? And again, they said that except in clinical trials, there's essentially none that are recommended. So in general, this was quite conservative. And part of that conservatism comes from this consensus approach. And for example, I was disappointed there was no discussion of vitamin D. With the Spanish flu of 1918, there have been theories that people out in the sun and ventilation, and of course with seasonal changes, that some sunlight and vitamin D are helpful. And that may be one reason why people get more easily ill in the winter. They have less vitamin D. Again, this is not a cure, but in terms of prophylaxis or prevention. There's also no mention of the BCG vaccine, which has been shown in some countries to have a factor of 10, an order of magnitude less deaths than countries that didn't have BCG. And then in terms of critical care, we talked about surfactant and ACE2 being key elements of the severity of disease. There was no reference to exogenous surfactant as it's done with infant respiratory distress syndrome, or ACE2 replacement or other ways to increase ACE2. So this was a little bit disappointing in that regard, very conservative, very generic guidelines. And I think we need more out-of-the-box thinking and more imagination. So let's go to antivirals. Now remember here, this is what a virus is. It invades living cells, uses the host metabolic machinery. Unlike miracle antibiotics which kill bacteria, such as penicillin, antivirals cannot kill viruses. That's because one cannot kill that which is not alive. We, again, emphasize that virus is not really alive, unlike bacteria. So that being said, what do antivirals do? They interfere with the process. So for example, this process, a little complicated, the fusion or binding of the virus to the cell can be prevented by monoclonal antibodies and chemostat mesylate. The endocytosis, or the virus coming into the cell, can potentially be inhibited by chloroquine, hydroxychloroquine. People have been talking about that. The next step is proteolysis. Leponavir, ritonavir are related to that. And remdesivir in translation and RNA replication, and there's also packaging and release of the virus. So all these steps can be slowed down. But as mentioned, none of these have been approved or considered to have enough clinical data to be recommended for use. They are in clinical trials. In fact, there was a study showing, in fact, with chloroquine and hydroxychloroquine, that there are more deaths with that because these drugs have potential toxic effects. So again, to summarize, antivirals slow down the virus, allowing the immune system to clear it. And we may need, as with HIV, perhaps a cocktail of drugs which will be necessary, not just one, but perhaps a cocktail. And I think we should be open-minded to that. There's a cautionary tale. In the Spanish influenza of 1918, there's been theory that aspirin actually may have caused many of the deaths. So here's an entry from the Pandemic Influenza Storybook. In February 1919, Edward's fever kept getting higher and higher. Aspirin was given to him by the half handful over and over. He sweated through his mattress. The doctor could not save his patient. So an article came out talking about this connection. So salicylates, which is aspirin, increased lung fluid and protein levels. In 1918, several authorities recommended the use of aspirin just before the October death spike. And they were recommending a dose of 1,000 milligrams every 3 hours, which is twice the actual safe dose for a whole day. And so a significant proportion of fatality may have been due to aspirin. So now let's talk about how the virus spreads. In terms of our framework, this is the horizontal axis here, the R0. So more about R0. SARS coronavirus 2 has an estimated R0 of 2 to 2.5 based on the initial estimates from the outbreak in China. Is that correct? So let's look at what this number is. The basic reproduction number, R0, is the number of cases generated by one case when everyone is susceptible. So 2 to 2.5 means that one person will infect, create 2 to 2.5 more cases. That's if everyone is susceptible. An R greater than 1 means exponential growth. Larger R means quicker spread. The effective reproduction number, R, without the naught, is the number of cases generated by one case in an actual population where some may be immune. So when people get immunity by infection or vaccination, the R may decrease over time. Now, if we go to the basic reproduction factor number, R naught, there are two aspects: the intrinsic factors, which are related to the nature of the virus. As we showed on the chart, some viruses are more transmissible than others. And the R may change with mutation. And then another is the extrinsic factors, the nature of the population. People are crowded, people are not crowded, people are social distancing, they're not social distancing. The R naught will change with the situation. So the nature of the virus, how is it transmitted, how long is it viable, what is the incubation period? These are all important questions. And if we look at the extrinsic factors, there's an equation, beta times tau. Beta is the number of infection-producing contacts. So social distancing, protective measures, and mass will influence that. And tau is the infectious period. So finding, isolating, testing infectious people quickly will reduce that tau. So those are the two factors, the actual contact dynamics and the contact time, beta and tau. So we'll talk about these two. In orange is the beta, and in blue is the tau. Key element will be the vaccination. So what are some of the methods of transmission? So we have direct methods, indirect methods, and vector methods. And many pathogens have different combinations of these. HIV, tuberculosis, chickenpox, Zika will have different methods of transmission. So for example, malaria will involve insect bites. So SARS coronavirus, the main is a direct transmission, person to person or droplet. Second is via fomites. Fomites are basically particles on surfaces. And the third possible method of transmission is fecal oral, or by contact and through the intestine. So how long can SARS coronavirus 2 be viable? I didn't use the word alive on purpose, but viable on surfaces. So droplets in the air up to 3 hours. And that means we need what are called droplet precautions. Masks and isolation, surgical masks, K94, N95, and cotton also has been shown to be relatively effective. And then on surfaces, we have variable duration of viability, and these are called fomites, as mentioned. And this results in what we would call contact precautions. So soap and water and alcohol for the hands, bleach and hydrogen peroxide for surfaces. So cleaning is very important. And PPE, so gowns, gloves, in addition to masks for contact precautions. So droplet precautions and contact precautions. So in terms of transmission, an important concept in respiratory diseases is the difference between upper respiratory and lower respiratory infections. The upper respiratory infections, the nose and the mouth and the throat, have a high transmissibility and a low fatality. These are common colds and some coronaviruses. The lower respiratory are SARS and MERS with a low transmissibility and high fatality. So you can see deeper down, it's harder to get it more transmissible. The problem with SARS coronavirus 2, it appears to be both upper respiratory found in the throat as well as lower respiratory. So study of this has been done in detail. The good news is that SARS coronavirus seems to replicate in the throat. A simple throat swab should be sufficient, and probably no need for the unpleasant, intrusive nasal swab. It's mostly spread by coughing or other release of aerosols. The bad news is seroconversion seems to take time. In other words, the development of antibodies up to 10 days. So people are infectious for a long period of time. And the antibodies don't seem to neutralize very effectively. And so like HIV, except for different reasons, vaccines may be a problem. So a cocktail of drugs may be very important. So some of the extrinsic factors are related to the primary mitigation strategies. So when we look at different countries, there's been enforced lockdown, like in China, unenforced lockdown with the EU and United States, and voluntary social distancing like Korea, and minimal restrictions with a hope for herd immunity like Sweden and initially the UK. So I want to focus on the voluntary social distancing in South Korea, which I'm quite familiar with, and that's been a model for many countries. So there are 4 factors that seem to have been related to the success. First is to intervene fast before it's a crisis. Second is to test early, often, and safely. Third is contact tracing, isolation, and surveillance. Fourth is to enlist the public's health. So remember that equation of R naught we talked about, the beta which is to minimize the contacts and reduce that effectiveness, and the tau, which is to minimize the time. So the elements, the measures that reduce the time are here: developing coronavirus test kits early, testing early, often, and safely, doing the contact tracing and isolating, and then the elements that reduce the beta, or the ability of people to infect others, are the public education, the social distancing, and the supplying and wearing of masks and mass messaging. So those are a multifactorial approach to reducing the ultimate R0. So secondary mitigation strategies don't really reduce the R0, but help with the healthcare response. Build more hospitals, as China did. Supply more ventilators, as Elon Musk famously proposed. Medical triage involving tragic decisions. Some people get a ventilator, some people do not. And to recruit more healthcare professionals. So an example in South Korea, the small things count. This is actually a government office. This is hand wash at every counter. Mask, this sign in Korean tells citizens how to get masks, which are provided at cost every week, 2 masks for each person in national health insurance. And there's a plastic barrier here between the worker and the visitor. Cleaning of public spaces, this is a bus stop, the car stops by, they wipe down the surfaces. There's actually their co-workers videotaping it, probably for documentation purposes. And in many offices, they do fever check. This is the infrared camera, and you can see the infrared. My temperature here is 94, so we can easily track whether we have a fever. So the question is, will there be a second wave? So this is the history of the influenza, Spanish flu, 1918 to 1919. There were actually 3 waves, with the majority of deaths in the US occurring during the second wave. So SARS, coronavirus, is less virulent in warm weather, but not completely. We see it in both the southern and northern hemispheres. There are cases in South America, Australia, and Africa. And it's highly infectious, we know that. So second wave is definitely a risk. And in fact, we've seen that in Singapore. Singapore had very effective control of the virus in February and March. And then around the middle of March, some imported cases started coming in. And then later in March, local cases. So second wave is definitely possible, even with very good measures. So testing, as I mentioned, is very important. There are 3 ways to test for COVID-19. So this is a graph of the amount of some analyte, what we're studying for, what we're measuring, and these are the days since onset of symptoms. So the first test is the RNA test. That's the one with the nasal swab. It's the real-time polymerase chain reaction. It takes about 2 to 3 hours to get a result. And then there's the viral antigen test, looking for spike protein or other proteins. It's an immunoassay. It takes about 10 minutes. It's a blood test. And these are what we call diagnostic tests that we have the virus, or that the patient has the virus. Then the next type of test, the third type of test, is the so-called antibody test that pick up IgG and IgM. IgM is an early antibody. It's also a protein immunoassay test. And we call that a serological test. And that means that the person with positive for that test had the virus. So this is a diagnostic test, the RNA and antigen test. The serological tests are the antibody tests. So there's one of the important things to note is that the nucleic acid RNA test has higher accuracy. The protein immunoassay has lower accuracy. In the case of antibody, there are many possible antibodies. So there are some problems with the antibody test. There's weak immunity we talked about, short-lasting immunity. There may be different antibodies, different people. Everyone's immune system is not the same. And the targets on the virus, the neutralizing spots might be different. And as I mentioned, limited accuracy. It's not as precise as the nucleic acid-based tests. But it's very important to remember that testing requires follow-up. Just testing alone is meaningless. You need contact tracing, quarantine, isolation, and of course, treatment decisions. So here's the question about mutation. What about mutation? So as I said, in the center of the virus, we have the RNA. It's important to note it's an RNA virus, not DNA. And the difference between RNA and DNA is RNA mutates much more readily. This has important implications. So this was a recent study. A couple of days ago, they studied not just many people have studied the virus variability. There's lots of variants out there, but this was actually functional characterization. In other words, looking at how infectious and how pathogenic is the virus. So they observed diverse mutations, including 6 mutations in these 11 patients in the spike protein. These variants showed a significant difference in cytopathic is killing the cell, effects, and the viral load up to 270-fold, providing direct evidence that the mutations are capable of substantially changing the pathogenicity. So this is very important because this is a picture of a Wuhan in January 2020, the emergency room, totally packed. And one thing about mutations is, in general, mutations in viruses and other pathogens tend to get less fatal. They like to spread. The virus obtains no benefit by killing people. It would rather spread without killing lots of people. So mutations tend to be less virulent. That's a little bit of a generalization, which is good news. But on the other hand, if there are no barriers to transmission, in other words, in very crowded environments where lots of people are infected and there's a high viral load, then the mutations can be moved towards the more pathogenic variety. So to avoid more pathogenic mutation, we must absolutely avoid these situations. And when we isolate people, we don't do cohort isolation where people with the disease are together, so they're still exchanging the virus, and hence mutations can occur. We ensure individual isolation. It's a very important point, which I've written about before. So I'll finish with what is to be done. What should individuals do? Of course, you should follow local governmental recommendations and requirements. Bear in mind that the great majority of cases are mild or even asymptomatic. Cleaning and hygiene are very important. Soap and water, alcohol, sanitizer disrupt that grease lipid membrane, so you destroy the virus. Covering the nose and mouth when coughing or sneezing, keeping your surfaces and areas clean. Social distancing, greater than 2 meters as much as possible, avoiding close contact with crowds, confined spaces, or anyone with symptoms, and wear a mask when in public spaces. People have talked about the reasons for the mask. Obviously, it prevents droplets from coming out from people who are symptomatic. There is some protection from droplets coming in, so long as you handle the mask carefully and don't reuse it for a very long time and so forth. And the third reason is social signaling that you're taking these measures as important. And also ventilating your home and work area when possible. These are not new measures. I mean, these were very common in the influenza epidemic in 1918 and 19. Cover each cough and sneeze with handkerchief. Avoid crowds. Walk to work. Do not spit on floor or sidewalks. Do not use common drinking cups. If you take ill, go to bed, send for a doctor, and so forth. So most important, if you have a cough, fever, and are difficulty breathing, contact your local authorities according to local requirements. So what should organizations do? Social distancing, minimizing or eliminating meetings, substituting the telephone or video conferences. If there must be face-to-face meetings, minimizing contact and establishing a safer distance. Managing contacts by flexible scheduling, shifts, avoiding rush hour, minimizing overlap. Smaller teams, if someone gets infected in a team, then you can trace them very quickly. Work entrances should have temperature testing. One novel method is to use a smell test, alcohol vinegar. So I know that the US military bases in Korea are using a smell test for people coming in. Place alcohol sanitizer in all work areas, especially near entrances, not just in the restrooms. Ventilation is very important. For hot climates, to reduce the air conditioning, and for enclosed areas, use ventilation with filtration systems, update the filter and upgrade if possible. The psychological aspects, so leaders in these organizations should encourage a positive support environment, not obviously by holding hands, but some other way of improving mental health and positive feeling. So most important, again, to encourage anyone with symptoms to contact the appropriate medical authorities. So what do we know about this virus? It is very tricky. How can we stop it? Only by destroying or having the immune system clear it. How does it cause disease? The type 1 pneumocytes are destroyed and ACE2 is disrupted. What are the prospects for a vaccine? It won't be easy, but it's possible. Can one be reinfected? These are likely false positive, possible immune failure. How does one test for COVID-19? 3 ways: RNA, antigen, antibody, each with their pros and cons. Do antibody tests work? Because immunity may not be absolute, likely not 100%. Does the virus mutate? Yes, and it's very important to individually isolate. Are effective antivirals possible? There's never been a curative antiviral possible. So it's like the proverbial philosopher's stone. And it's very important. If we just depend on some magic cure, then all the other measures that we have to do can be potentially ignored. So I'll end with a quote from Abraham Lincoln. Annual message to Congress in 1862. As our case is new, so we must think anew and act anew. My prediction is that this crisis will inspire entirely new methods of diagnosis and treatment. That's the subject of another video. In fact, if we don't think anew or act anew, we may be forced to live with COVID-19 for the indefinite future. So thank you very much for listening. Please take care. And for more videos like this, please subscribe to the Mini Medical School YouTube channel. Thank you.